Respected Chief Guest of the Day, Dr. Megha Jayaprakash, Head of the Department of Zoology, Dr. Leji, Program Convener and Coordinator, Mrs. Preeti, Executive Member, Sri Aji SRM, Head of the Department of Chemistry, Dr. Jolly A, IQC Coordinator, Dr. Babita GS, Dr. Birishma, other club members, Mrs. Avani, Dr. Shainu, Dr. Smita, my colleagues and other delegates, parents and my dear friends. നമുക്കറിയാം, നമ്മുടെ പ്രായഭേദമന്യേ എല്ലാവർക്കും ഉപകാരപ്രദമാകുന്ന തരത്തിലുള്ള ഒരു ബോധവൽക്കരണ ക്ലാസ്, അതും വളരെ അനുഭവ സമ്പത്തുള്ള ഒരു ഗൈനക്കോളജിസ്റ്റിലൂടെ തന്നെ നമ്മളിലേക്ക് എത്തിക്കുവാൻ ശ്രമിച്ചിരിക്കുന്ന എല്ലാ അണിയറ പ്രവർത്തനങ്ങളെയും ഞാൻ ആദ്യമായി അഭിനന്ദിക്കുന്നു. അതോടൊപ്പം തന്നെ സ്വമനസ്സോടെ ഈ ഒരു വെബിനാറിന്റെ ഭാഗമാകാൻ മുന്നിട്ടിറങ്ങിയിരിക്കുന്ന നമ്മുടെ വിദ്യാർത്ഥികളെയും അതോടൊപ്പം തന്നെ അവരുടെ രക്ഷിതാക്കളെയും ഞാൻ അഭിനന്ദിക്കുകയാണ്. നമുക്ക് ഏവർക്കും അറിയാം, നമ്മുടെ ഈ ഒരു ജീവിത കാലഘട്ടത്തിലൂടെ നാം കടന്നു പോകുമ്പോൾ ഗൈനക്കോളജിക്കൽ ഇഷ്യൂസ് അത് നമ്മൾ എല്ലാവരും ഫേസ് ചെയ്യേണ്ട ഒരു വിഷയം തന്നെയാണെന്ന കാര്യം. ചിലപ്പോൾ അത് അഡോളസൻസ് പീരീഡിലാകാം, അല്ലെങ്കിൽ യൗവനത്തിലേക്കാകാം, അല്ലെങ്കിൽ മിഡിൽ ഏജിലാകാം, ഒന്നുമല്ലെങ്കിൽ ഓൾഡ് ഏജിൽ. അഡോളസൻസിലുള്ള നമ്മുടെ വിദ്യാർത്ഥിനികളെ സംബന്ധിച്ചിടത്തോളം ശാരീരികവും മാനസികവുമായ ഒരുപാട് രൂപമാറ്റങ്ങൾ, വ്യതിയാനങ്ങൾക്ക് വിധേയമായി കൊണ്ടിരിക്കുന്ന ഈ ഒരു അവസരത്തിൽ കുട്ടികൾക്ക് വേണ്ട ബോധവൽക്കരണം നൽകാനും അവരുടെ സംശയങ്ങൾ ദൂരീകരിക്കാനും അവരെ ഗൈഡ് ചെയ്യാനും അധ്യാപകർക്കും രക്ഷിതാക്കൾക്കും ഒരു പരിധിവരെ മാത്രമേ സാധിക്കൂ എന്നതാണ് സത്യം. മുൻകാലങ്ങളിലായിരുന്നെങ്കിൽ കൂട്ടുകുടുംബങ്ങളിൽ ഗ്രാൻഡ് പാരന്റ്സ് ഒക്കെ ഉപദേശങ്ങൾ നൽകാനുണ്ടായിരുന്നു. ഇന്നത്തെ ഈ തിരക്ക് പിടിച്ച ഈ ഒരു വേളയിൽ നമ്മൾക്ക് നമ്മുടെ കുട്ടികളിൽ വേണ്ട ശ്രദ്ധ ചെലുത്താൻ പറ്റുന്നില്ല എന്നതാണ് സത്യം. അതുകൊണ്ട് തന്നെ ഈ തരത്തിലുള്ള വെബിനാറിലൂടെ നമുക്ക് നമ്മുടെ ആരോഗ്യത്തെ, അതായത് നമ്മൾ ഫിസിക്കലി ഫിറ്റ്നസ് ആണെങ്കിൽ മാത്രമേ നമുക്ക് മെന്റൽ ഫിറ്റ്നസ് കൈവരിക്കാനും, അതുപോലെ തന്നെ ഏതൊരു തൊഴിൽ മേഖലയിലാണ് നമ്മൾ പ്രവർത്തിക്കുന്നത് അവിടെയൊക്കെ നമുക്ക് ശോഭിക്കാനും സാധിക്കുകയുള്ളൂ എന്നതാണ് സത്യം. അതുകൊണ്ട് തന്നെ നമ്മുടെ ഈ ഒരു വെബിനാറിന്റെ പ്രസക്തി വളരെ ഏറെയാണ്. ഇവിടെ എനിക്ക് പറയാനുള്ളത് നമ്മുടെ വിദ്യാർത്ഥികളോടാണ്. അവരുടെ രക്ഷിതാക്കളൊപ്പം ഉണ്ടെങ്കിൽ രക്ഷിതാക്കളെ കൂടി ഈ ഒരു വെബിനാറിന്റെ ശ്രോതാക്കളാക്കി മാറ്റാൻ ശ്രമിക്കുക. ഇനി വരുന്ന ഒരു തലമുറയിലേക്ക് നമ്മുടെ ഈ ഒരു അറിവുകൾ പങ്കുവെക്കാനും അതുപോലെ ആരോഗ്യപ്രദമായ ഒരു ജീവിതം കൈവരിക്കാനും നല്ലൊരു കുടുംബജീവിതത്തെ നയിക്കാനും ഇതുപോലെയുള്ള വെബിനാറുകൾക്ക് സാധിക്കും. അതുകൊണ്ട് എല്ലാവരുടെയും അനുമതിയോടെ ഈ ഒരു വെബിനാർ ഞാൻ ഉദ്ഘാടനം നിർവഹിക്കുകയാണ്. നന്ദി, നമസ്കാരം.
Thank you, ma'am, for your valuable words. Now I invite Sri Aji SRM, SN Trust Executive Member, to felicitate the function.
Namaste. ഏറെ ബഹുമാനിയായ പ്രിൻസിപ്പൽ, ബഹുമാനിയായ ലജി ടീച്ചർ, ഇന്നത്തെ വിശിഷ്ടാതിഥി ബഹുമാനിയായ മേഘമ്മ, ടീച്ചർ ഉൾപ്പെടെ ഈ വെബിനാറിന്റെ ഭാഗമായിട്ടുള്ള ഏറെ ബഹുമാനിയെ പ്രിൻസിപ്പൽ സൂചിപ്പിച്ച പോലെ ഏറ്റവും കാര്യമാത്ര പ്രസക്തമായ ഒരു വിഷയം, അതും പ്രശസ്തയായ ഒരു ഗൈനക്കോളജിസ്റ്റിന്റെ സാന്നിധ്യം, അത് തന്നെ ഈ സംരംഭത്തെ സമ്പന്നമാക്കുന്നു. തീർച്ചയായും ഇതിന്റെ ഗുണഭോക്താക്കളായി മാറുവാൻ മുഴുവൻ തലത്തിലുള്ള വിഭാഗങ്ങൾക്കും കഴിയും എന്ന കാര്യത്തിലും സംശയമില്ല. ഇത്തരത്തിലൊരു പരിപാടി സംഘടിപ്പിക്കുവാൻ മുൻകൈയെടുത്ത ഇതിന്റെ സംഘാടകരെ എസ് എൻ ട്രസ്റ്റിന്റെ പേരിൽ അഭിനന്ദിക്കുവാൻ ഞാൻ ഈ അവസരം വിനിയോഗിക്കുന്നു. അതോടൊപ്പം തന്നെ ഈ സംരംഭത്തിന്റെ ലക്ഷ്യപ്രാപ്തിയിലേക്ക് ചെന്നടയട്ടെ എന്ന് പ്രാർത്ഥിച്ചുകൊണ്ട് എല്ലാവിധ ആശംസകളും നേർന്നുകൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ ഉപസംഹരിക്കുന്നു. നന്ദി, നമസ്കാരം.
Thank you, sir. I invite Dr. Jolly Arvind, Head of Department of Chemistry, for the felicitation.
ഹലോ ഹലോ
ടീച്ചർ
കേൾക്കാമോ?
ടീച്ചർ
ഹലോ ഹലോ
കേൾക്കാം ടീച്ചർ.
ഹലോ 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 ഗുഡ് ആഫ്റ്റർനൂൺ. Respected Principal KC Preeti teacher, IQC Coordinator and Senate Member Dr. Babita, Zoology HOD Ligi teacher, and our distinguished guest Dr. Megha Jayaprakash, and Dr. Binishma Raju, Preeti teacher, and other teachers, students. First of all, I congratulate our respected resource person, Dr. Megha Jayaprakash, who is willing to conduct the webinar on this relevant topic for our college. I express my sincere and heartfelt felicitation for the very informative and socially useful topic selecting for our students. For the core team of Zoology Department, especially the coordinator, Dr. Ligi teacher, I once again congratulate all the Zoology members for conducting such a useful topic for this webinar. Once again, I felicitate for this session. Thank you very much. Okay.
Thank you, ma'am. I also invite Dr. Soju S, Head of the Department of Commerce, on behalf of the IQAC of our college, for the felicitation.
ബഹുമാനപ്പെട്ട പ്രിൻസിപ്പൽ ഡോക്ടർ KC Preeti ടീച്ചർ, HOD സുവോളജി ഡിപ്പാർട്ട്മെന്റ് ഡോക്ടർ ലജി ടീച്ചർ, സ്വാഗതം ആശംസിച്ച പ്രീതി ടീച്ചർ, ആശംസകൾ അർപ്പിച്ച ബഹുമാനപ്പെട്ട SN ട്രസ്റ്റ് എക്സിക്യൂട്ടീവ് മെമ്പർ ശ്രീ അജി SRM, കെമിസ്ട്രി വിഭാഗം മേധാവി മുൻ പ്രിൻസിപ്പളുമായിരുന്ന ഡോക്ടർ ജോളി അരവിന്ദ്, ബബിത ടീച്ചർ, ഈ വെബിനാറിന് കൃതജ്ഞത അർപ്പിക്കുന്ന ഡോക്ടർ ബിനിഷ്മ രാജു, പ്രിയപ്പെട്ട സഹപ്രവർത്തകരെ, വിദ്യാർത്ഥികളെ, രക്ഷകർത്താക്കളെ, നമുക്കെല്ലാം അറിയാവുന്നതുപോലെ COVID-19 പാൻഡമിക്കിന്റെ ഒരു തീവ്രത അനുഭവിച്ചുകൊണ്ടിരിക്കുന്ന ഈ കാലഘട്ടത്തില് ശിവഗിരി ശ്രീനാരായണ കോളേജിലെ വിവിധ ഡിപ്പാർട്ട്മെന്റുകളും IQAC-യുമായി സഹകരിച്ചുകൊണ്ട് നിരവധി പ്രോഗ്രാമുകൾ നമ്മൾ നടത്തിക്കൊണ്ടിരിക്കുകയാണ്. നമുക്കെല്ലാം അറിയാം, നമ്മുടെ വിദ്യാർത്ഥികൾക്കും മറ്റു കോളേജിലെ വിദ്യാർത്ഥികൾക്കും അധ്യാപകർക്കും എല്ലാം അറിയുന്നത് പോലെ നമ്മുടെ IQAC-യുടെ നേതൃത്വത്തിലും നമ്മുടെ കോളേജിലെ മറ്റ് ഡിപ്പാർട്ട്മെന്റുകളുടെ നേതൃത്വത്തിലും നമ്മളൊരു സൈക്കോളജിക്കൽ കൗൺസിലിംഗ് നമ്മൾ നടത്തി നമ്മുടെ വിദ്യാർത്ഥികൾക്കായിട്ട്. അതുപോലെ തന്നെ എക്കണോമിക്സ് ഡിപ്പാർട്ട്മെന്റ്, മലയാളം ഡിപ്പാർട്ട്മെന്റ്, ഇംഗ്ലീഷ് ഡിപ്പാർട്ട്മെന്റ് തുടങ്ങിയ നിരവധിയായ ഡിപ്പാർട്ട്മെന്റുകൾ നിരവധി ഓൺലൈൻ പ്രോഗ്രാമുകൾ വെബിനാറുടെ രൂപത്തിലായാലും ക്വിസ് കോമ്പറ്റീഷന്റെ രൂപത്തിലായാലും എല്ലാം ഭാഗികമായിട്ടെങ്കിലും നമ്മുടെ വിദ്യാഭ്യാസം അല്ലെങ്കിൽ അധ്യയനവും അതുപോലുള്ള കലാലയത്തിലെ മറ്റു പ്രവർത്തികളും നിലനിർത്തുക എന്ന ഉദ്ദേശത്തിന്റെ ഭാഗമായിട്ട് നമ്മൾ നിരവധി പരിപാടികൾ സംഘടിപ്പിച്ചുകൊണ്ടിരിക്കുകയാണ്. തീർച്ചയായിട്ടും നമ്മുടെ കോളേജിലെ ഹെൽത്ത് എഡ്യൂക്കേഷൻ ക്ലബും സുവോളജി ഡിപ്പാർട്ട്മെന്റും കൂടെ സംയുക്തമായിട്ട് ഇത്തരത്തിലൊരു പ്രോഗ്രാം, അതും ഇന്ന് കേരളത്തിലെ അറിയപ്പെടുന്ന ഒരു ഗൈനക്കോളജിസ്റ്റ് ആയിട്ടുള്ള ഡോക്ടർ മേഘ ജയപ്രകാശിനെ പോലൊരു വ്യക്തിത്വത്തെ കൊണ്ടുവന്ന് റിസോഴ്സ് പേഴ്സണായി കൊണ്ടുവന്ന് ഇത്തരത്തിലൊരു പരിപാടി നടത്തുന്നതിന് എല്ലാ ഭാവുകങ്ങളും എല്ലാ ആശംസകളും IQAC-ക്ക് വേണ്ടി ഞാൻ നേരുന്നു. നന്ദി.
Thank you, sir. Today, We are very pleased to welcome Dr. Megha Jayaprakash, our special guest. Good afternoon, ma'am. Thank you for being with us this afternoon. Dr. Megha is currently working as an associate professor at Government Medical College, Thrissur, and she is specialized in obstetrics and gynecology. And today, she'll be sharing with us her expert opinion on the topic common gynec problems from birth to post-menopause. With that, I ask that you give your full attention to Dr. Megha and help me in welcoming her to the webinar. Dr. Megha, over to you.
Thank you. Am I audible?
Yes, ma'am.
Right. So before I start the presentation, I would first of all like to thank the principal of SN College, Varkala, Dr. Preeta Madam, the HOD of Zoology, Dr. Reggie Madam, the coordinator of this program, Ms. Preeti, and everybody who's on the executive committee, the organizing committee, especially Shri Aji SRF, and all others who have put together this webinar and also invited me to be a resource person. It's an absolute privilege and pleasure. I hope you gain something from this. So shall we go on to the presentation now? So I have been told to talk on common health issues from birth to postmenopause. Is my PowerPoint visible to everyone?
Yes, ma'am.
Okay.
Yes, ma'am.
So the outline of my presentation will be based on the different phases in a woman's life, starting from the time she's born to her childhood, to her adolescence, to her reproductive age, perimenopause, and postmenopause. So let's start with the birth of a newborn baby girl. I'm okay with ഇംഗ്ലീഷിലാണെങ്കിലും കുഴപ്പമില്ല, മലയാളം ആണെങ്കിലും കുഴപ്പമില്ല. ഏതാ വേണ്ടെന്ന് വെച്ചാൽ അതിൽ സംസാരിക്കാം. ഐ തിങ്ക് രണ്ടും കൂടി ഇടയ്ക്കിടയ്ക്ക് ഞാൻ ഉപയോഗിക്കാം. Hope that's okay.
Okay, ma'am.
Okay. Right. So ഒരു കുഞ്ഞ് ജനിച്ചു, പെൺകുട്ടിയാണ്, സന്തോഷമായി എല്ലാവർക്കും. പെട്ടെന്ന് അലാമിംഗ് ആയിട്ടുള്ള ഒരു കാര്യം, കുഞ്ഞിന്റെ ഡയപ്പറിൽ ബ്ലഡ് കണ്ടു, അല്ലെങ്കിൽ ചെറുതായിട്ടൊരു രക്തം കലർന്ന ഒരു ഡിസ്ചാർജ് കണ്ടു. കുഞ്ഞിന്റെ എക്സ്റ്റേണൽ ജെനിറ്റേലിയ ഒക്കെ സ്വോളൻ ആയിട്ട് ഇരിക്കുന്നു. എന്തുകൊണ്ടും പേടി ഉണ്ടാവാൻ സാധ്യതയുള്ള ഒരു സിറ്റുവേഷൻ ആണ്, അല്ലേ? സോ നിങ്ങൾ അറിഞ്ഞിരിക്കേണ്ട ഒരു കാര്യം, ഇത് എല്ലാ കുഞ്ഞുങ്ങളിലും ഉണ്ടാകണം എന്നില്ല, പക്ഷേ ഫിസിയോളജിക്കൽ ആയിട്ട് സംഭവിക്കാവുന്ന സ്യൂഡോ മെൻസ്ട്രുവേഷൻ എന്ന് പറഞ്ഞൊരു സംഭവമാണ്. നിയോനേറ്റ്സിൽ യൂട്രൈൻ ബ്ലീഡിംഗ് വരുന്നു. അതെന്തുകൊണ്ട് എന്ന് ചോദിച്ചാൽ, ഇത്രയും നാള് അമ്മയുടെ ശരീരത്തിലെ ഹോർമോൺസിന്റെ ഇൻഫ്ലുവൻസിലാണ് കഴിഞ്ഞത്. പെട്ടെന്ന് പുറത്തെടുക്കുമ്പോൾ ആ ഹോർമോൺസിൽ നിന്നൊരു വിഡ്രോയൽ ആണ് ബ്ലീഡിംഗ് ആയിട്ട് പ്രകടമാകുന്നത്. സോ ആ ഈസ്ട്രജന്റെ ഒരു ഇഫക്റ്റ് കാരണമുള്ള ഒരു സ്വോളൻ ആൻഡ് റെഡ് ജെനിറ്റേലിയയും ഹൈമനൽ ടാഗ്സ് ഒക്കെ കുറച്ച് വീർത്തിട്ടൊക്കെ ഇരിക്കാം. ഇത് തികച്ചും ഫിസിയോളജിക്കൽ ആണ് എന്ന് മാത്രം അറിഞ്ഞിരിക്കുക. ഓക്കെ. ഇനി അടുത്തത് ഒരു ടോഡ്ലർ ആയി, അതായത് എണീറ്റ് നടന്ന് കളിച്ച് ഒക്കെ തുടങ്ങി 2, 3, 4, 5 വയസ്സ് വരെയൊക്കെയുള്ള സ്ഥിതിയിൽ ആ സിറ്റുവേഷനിൽ എന്തൊക്കെ ഗൈനക് പ്രോബ്ലംസ് ആയിട്ട് വരാം. vulvovaginitis, precocious puberty. ഇത് രണ്ടുമാണ് ഞാൻ തിരഞ്ഞെടുത്തിരിക്കുന്നത്. കാര്യം വെച്ചാൽ ഇതിനെ കുറിച്ചായിട്ട് കാണുന്നതും കുറച്ച് അധികം കുറച്ച് അറിഞ്ഞിരിക്കേണ്ടതുമായിട്ടുള്ള 2 കണ്ടീഷൻസ്. സോ അതില് വൾവോ വെജൈനൈറ്റിസ് എന്നുള്ള വാക്കിൽ തന്നെ അറിയാം എന്തോ ഒരു ഇൻഫെക്ഷൻ എന്നാണ് നമ്മൾ അത് വിചാരിക്കുക. അപ്പോ ശരിക്കും എന്താണ് ഈ പ്യൂബർട്ടി ആയിട്ടില്ല, ഇത് ഒരു പ്രവർത്തനവും ഇല്ല ശരീരത്തിൽ. അപ്പോ എന്താ സംഭവിക്കുന്നത്? വിരാമം വന്ന ഒരു സ്ത്രീയുടെ പോലെ പോസ്റ്റ് മെനോപോസൽ സ്റ്റേജിലുള്ള ലോ ലെവൽസ് ആണ്. എന്താ ഉണ്ടാവുന്ന വെച്ചാല് വെജൈനയും അവിടുത്തെ സ്കിൻ എല്ലാം ഏട്രോഫിക് ആണ്, തിന്നാണ്, ആകാനും ബ്ലീഡ് ചെയ്യാനും ഇൻഫെക്ഷന് കൂടുതലാണ്. മാത്രമല്ല ഈ പ്രായം ഞാൻ ഇട്ടിരിക്കുന്ന പടം എല്ലാരും ഒന്ന് ശ്രദ്ധിക്കുക. ഏതാണ്ട് ഇങ്ങനാണ് ശ്രദ്ധിച്ചിട്ടുണ്ടോ? അവരുടെ വളരെ ഫ്ലെക്സിബിലിറ്റിയും പ്രത്യേകിച്ചും ഇട്ടിരിക്കുന്ന അത്രയും കാണത്തില്ല. അപ്പോ ഈസിലി ട്രോമറ്റൈസ്ഡ് ആകാനുള്ള സാധ്യതയും അണുക്കൾ പെട്ടെന്ന് കയറാനുള്ള സാധ്യതയും കൂടുതലാണ്. പിന്നെ ഈ അവസ്ഥയിൽ വേറൊരു ഒരു ഫിനോമിനൻ ഇസ് പാരന്റൽ സൂപ്പർവിഷൻ കുറച്ച് കുറയുന്ന സമയമാണ്. ബിക്കോസ് അതുവരെയ്ക്ക് ഡയപ്പേഴ്സ് മാറ്റി നമ്മുടെ മടുത്തിരിക്കുന്ന സമയമാണ്. കുഞ്ഞ് കുറച്ച് വലുതായി കുറച്ചൊക്കെ തന്നെ ടോയ്ലറ്റിലൊക്കെ പോയി തുടങ്ങുന്ന അവസ്ഥ വരെയും ഇതൊക്കെ 7-8 വയസ്സ് വരെ ഫ്രണ്ട് ടു ബാക്ക്, അതായത് പോകുന്നേയും വെജൈനയുടെ അവിടെ നിന്ന് താഴോട്ട് ആയിരിക്കില്ല തുടച്ച് വൃത്തിയാക്കുന്നത്. അതൊക്കെ പ്രത്യേകം നമ്മൾ ശ്രദ്ധിക്കുകയും ആ സമയം ശരിക്കും നമ്മളുടെ ശ്രദ്ധ വേണ്ട സമയം തന്നെയാണ്. അപ്പോ ഈ സമയത്ത് ഉണ്ടാകുന്ന ഇൻഫെക്ഷൻസ് ബാക്ടീരിയൽ ആകാം, ഫംഗൽ ആവാം, പിന്നെ പിൻവേംസ്, അതായത് കൃമികടി എന്ന് പറയുന്നത് മലദ്വാരത്തിന്റെ ചുറ്റും ഒക്കെ കൃമികളൊക്കെ വന്നിരിക്കുന്നതായിട്ടും കാണാം. അത് ഈ കുട്ടികളെ താഴേന്ന് മുകളിലോട്ട് തുടയ്ക്കുമ്പോൾ അത് ഇങ്ങോട്ടേക്കും വരികയും അവിടെയൊക്കെ ഇൻഫെക്ഷനും എക്സ്കോറിയേഷനും ഉണ്ടാവുകയും ചെയ്യുന്നു. മാത്രമല്ല ആ കുഞ്ഞിന്റെ തൊലിക്ക് ചേരാത്ത ചില വസ്ത്രങ്ങൾ, അത് അല്ലെങ്കിൽ സോപ്പ്, ഡിറ്റർജന്റിൽ കഴുകുന്നതിന് ഒക്കെ കുട്ടിക്ക് അലർജി ഉണ്ടാവാം. പിന്നെ അപൂർവം അല്ല, ഇടയ്ക്കൊക്കെ ഞങ്ങൾ കാണാറുണ്ട് ഈ പ്രായത്തിൽ കുറച്ച് എക്സ്പെരിമെന്റേഷൻ കൂടുതലുള്ള ഒരു അവസ്ഥയാണ്. അവര് ചിലപ്പോൾ ഫോറിൻ ബോഡീസ് ടോയ്സ് വരെ അതിനകത്ത് ഒരു ഫിനോമിനൻ നമ്മൾ കണ്ടിട്ടുണ്ട്. അങ്ങനെയാകുമ്പോൾ അത് കുഞ്ഞ് പറയത്തോ ഇല്ല. കുറെ ദിവസം കഴിഞ്ഞ് ഇൻഫെക്ഷന്റെ നാറ്റം അടിച്ച് ഡിസ്ചാർജ് ആവുമ്പോഴായിരിക്കും നമ്മളുടെ അടുത്ത് എത്തുന്നത്. അങ്ങനെ ഒരു സംശയം ഉണ്ടെങ്കിൽ നമ്മൾ സ്കാൻ ചെയ്യിക്കും. പിന്നെ അത് അനസ്തീഷ്യ കൊടുത്തിട്ടൊക്കെയാണ് അത് എടുക്കുന്നത് പുറത്തോട്ട്. പിന്നെ 5% കുഞ്ഞുങ്ങളിൽ നമ്മൾ എപ്പോഴും മനസ്സിൽ കരുതേണ്ടത് എല്ലാ ഡിസ്ചാർജും ഇൻഫെക്ഷനോ ഈ പറഞ്ഞ കാര്യങ്ങളോ ആകണമെന്നില്ല. കുഞ്ഞിനെ വളരെ സ്വകാര്യമായിട്ട് ഇരുത്തി സമാധാനത്തിൽ ചോദിച്ചെങ്കിലും പ്രശ്നങ്ങളുണ്ടോ, എന്തെങ്കിലും ഒരു പോസിബിലിറ്റി ഓഫ് സെക്സ് ഉണ്ടോ എന്ന് നമ്മൾ ഉറപ്പുവരുത്തണം. പിന്നെ അത് TV ഇൻഫെക്ഷൻ എന്ന് പറഞ്ഞാൽ ട്രൈക്കോമോണിയാസ് വെജൈനാലിസ് എന്ന് പറഞ്ഞ പ്രോട്ടോസോൺ പാരസൈറ്റ്, അത് ശരിക്കും പറഞ്ഞാൽ ആ കുഞ്ഞിന്റെ സ്വാബ് എടുത്ത് നോക്കുമ്പോൾ അത് കാണുകയാണെങ്കിൽ ഈ സാധ്യത നമ്മൾ എന്തായാലും മനസ്സിൽ വെക്കണം. അത് കുറച്ചുകൂടി സാധ്യത ദൃഢമാവുകയാണ്. അതായത് TV ഇൻഫെക്ഷൻ യൂഷ്വലി സെക്ഷലി ട്രാൻസ്മിറ്റഡ് ആണ്, അല്ലെങ്കിൽ ഇന്റിമേറ്റ് കോണ്ടാക്റ്റിൽ മാത്രമാണ് അഡൾട്ട്സ് ഈ കുഞ്ഞുങ്ങൾക്ക് കിട്ടുന്നത്. ഈ അവസ്ഥയിൽ തന്നെ വളരെ വളരെ റെയർ ആണെങ്കിലും വെജൈനയുടെ അകത്ത് ചില സോഫ്റ്റ് ടിഷ്യൂ ട്യൂമേഴ്സ് ലൈക്ക് സാർക്കോമാസും ഈ ഡിസ്ചാർജിന് കാരണമാകാം. അപ്പോൾ എല്ലാം ഒരു പ്രീ പ്യൂബർട്ടൽ ചേഞ്ച് മാത്രമാണ് എന്ന് വിചാരിക്കാൻ പാടില്ല. ഈ അവസ്ഥകളൊക്കെ ആകാം. അപ്പൊ ഇതിൽ നിന്നൊക്കെ എന്താ മനസ്സിലാകുന്നത്? തന്നെത്താനെ ദയവ് ചെയ്ത് ട്രീറ്റ് ചെയ്യാതിരിക്കുക. ഓവർ ദ കൗണ്ടർ മെഡിസിൻ കടയിൽ പോയിട്ട് എന്തെങ്കിലും ഒരു ഓയിൻമെന്റ് തായോ, ഞങ്ങൾക്ക് ഫംഗൽ ഇൻഫെക്ഷൻ ആണ്, ബാക്ടീരിയൽ ഇൻഫെക്ഷൻ ആണെന്ന് പറഞ്ഞിട്ട് എല്ലാം കൂടി ഉള്ള ഒരു ഒറ്റമൂലി വാങ്ങി പെരട്ടാതിരിക്കുക. ദയവ് ചെയ്ത് ഒരു ഗൈനക്കോളജിസ്റ്റിനെയോ ഡെർമറ്റോളജിസ്റ്റിനെയോ പീഡിയാട്രിഷ്യനെയോ കാണിക്കുക. അവര് ഇതെല്ലാം ഹിസ്റ്ററി എടുത്ത് എക്സാമിൻ ചെയ്ത് വേണമെന്ന് വെച്ചാൽ സ്വാബ് ചെയ്യും. മൈക്രോബയോളജിക്കൽ കൾച്ചേഴ്സിന് വിട്ട് അതിന് കൃത്യമായിട്ടുള്ള ചികിത്സ ചെയ്യുന്നതാണ് ഉത്തമം. പിന്നെ ചിലപ്പോൾ ഞാൻ പറഞ്ഞ പോലെ പ്രീ പ്യൂബർട്ടൽ വൾവോവജൈനൈറ്റിസ് ആ ഹോർമോൺ കുറവ് ആയതുകൊണ്ട് മാത്രം ഉണ്ടാകുന്നതായിരിക്കാം. അങ്ങനെയാണെങ്കിൽ ചിലപ്പോൾ കുറച്ച് വിനീഗർ വാഷ് കൊണ്ടും ഇമോളിയൻസ്, അതായത് സൂത്തിന്ന് ചില തൊലിപ്പുറത്ത് പരട്ടുന്ന ചില എമോളിയൻസും കൊണ്ട് തന്നെ ചികിത്സ കറക്റ്റ് ആകും. പിന്നെ ഓഫ് കോഴ്സ് കുട്ടീനെ ഹൈജീൻ പഠിപ്പിക്കുകയും അത് സൂപ്പർവൈസ് ചെയ്യുകയും വേണ്ടി വരും. ഇനി അടുത്ത കണ്ടീഷൻ ഈ പ്രായത്തിൽ കാണുന്ന പ്രികോഷ്യസ് പ്യൂബർട്ടി, അതായത് ആർത്തവത്തിലേക്ക് എത്തുന്നതിന് മുന്നേ തന്നെ തുടങ്ങുന്ന
ഹരിലാൽ, this is muted. Ma'am? Harilal has muted the speaker.
Ma'am.
Please unmute.
Am I audible now?
Now audible.
യെസ്, ഓക്കെ. ഞാൻ പറഞ്ഞതിൽ എവിടം വരെ കേട്ടു എന്ന് എനിക്ക് ഉറപ്പല്ല. പ്രികോഷ്യസ് പ്യൂബർട്ടി തൊട്ട് കേട്ടായിരുന്നോ?
Yes, from this slide.
ഓക്കെ, ലെറ്റ്സ് കണ്ടിന്യൂ. സോ ഞാൻ പറഞ്ഞു വന്നത് പ്രികോഷ്യസ് ആയിട്ടുള്ള പ്യൂബർട്ടി, അതായത് പ്രതീക്ഷിക്കുന്നേക്കാളും മുന്നേ തന്നെ ഒരു ആർത്തവത്തിലേക്ക് പോകുന്ന ഡെവലപ്മെന്റ് എല്ലാം പ്രകടമാകുക, അത് തീർച്ചയായിട്ടും ആ കുടുംബത്തിനും ആ കുട്ടിക്കും വളരെ ഒരു സൈക്കോളജിക്കലി അവർ അപ്സെറ്റ് ആകുന്ന ഒരു സിറ്റുവേഷൻ ആണ്. അപ്പോൾ ആദ്യം അറിയേണ്ടത് ഏത് പ്രായത്തിലാണ് ഇതൊക്കെ നമ്മൾ ശരിക്കും നോർമൽ എന്ന് പറയുക. ഈ പ്രികോഷ്യസ് എന്ന് പറയണമെങ്കിൽ ഈ ആർത്തവത്തിലേക്ക് പോകുന്ന പ്യൂബർട്ടൽ ചേഞ്ചസ്, മെൻസ്ട്രേഷൻ അല്ല, ആ ശരീരത്തിൽ പ്രകടമാകുന്ന മാറ്റങ്ങൾ 8 വയസ്സിന് മുന്നേ തന്നെ തുടങ്ങുക. അതല്ലാന്നുണ്ടെങ്കിൽ മെൻസ്ട്രേഷൻ ബിഫോർ 10 years, അതായത് ആർത്തവം തന്നെ ബ്ലീഡിംഗ് ആയിട്ട് തന്നെ 10 വയസ്സിന് മുന്നേ പ്രകടമാകുക. ഇതെല്ലാം ടെക്നിക്കലി തിയറിറ്റിക്കലി ദിസ് ഇസ് പ്രികോഷ്യസ്. ഇത് നേരത്തെയാണ്. അപ്പം എന്തുകൊണ്ടാണെന്ന് ചോദിച്ചാല് 8 വയസ്സിന് മുന്നേ ഒക്കെ തന്നെ പ്രകടമാകുകയാണെങ്കിൽ ഡെഫിനറ്റ്ലി എന്തെങ്കിലും പെത്തോളജിക്കൽ കോസസ് ഉണ്ടോ എന്ന് നമ്മൾ ഇവാലുവേറ്റ് ചെയ്യണം, റൂൾ ഔട്ട് ചെയ്യണം. അത് ഹൈപ്പോതലാമസും പിറ്റ്യൂട്ടറി മാതിരി ബ്രെയിനിന് അകത്തുള്ള കണ്ടീഷൻസ് തൊട്ട് അഡ്രീനൽ ഗ്രന്ഥി, പിന്നെ ഓവറീസ്, ഇതിലൊക്കെ ഉണ്ടാകാവുന്ന ചില ട്യൂമേഴ്സ് അല്ലെങ്കിൽ ചില എൻഡോക്രൈനോളജിക്കൽ കണ്ടീഷൻസ് കാരണം ഈ അവസ്ഥ സംഭവിക്കാം. അപ്പോൾ ഒരു ഫുൾ ഇവാലുവേഷൻ വേണ്ടിവരും with the help of a gynecologist and an endocrinologist. Of course, ആ കുടുംബത്തിനും ആ കുഞ്ഞിന് വളരെയധികം സൈക്കോളജിക്കൽ സപ്പോർട്ട് വേണ്ട ഒരു അവസ്ഥയാണ് പ്രിക്കോഷ്യസ് പ്യൂബർട്ടി. ഇനി അടുത്ത സ്റ്റേജിലോട്ട് നമുക്ക് പോകാം. അത് എഡോളസൻസ്. ആ പടം കണ്ടല്ലോ, ഇത് തന്നെയാണ്, അതിന് കൂടുതലൊന്നും പറയേണ്ട കാര്യമില്ല. ഇതാണ് അവരുടെ ആ ഒരു സ്റ്റേജ്. They are so self engrossed with themselves and their groups. അവർക്ക് അവരുടെ ഗ്രൂപ്പുകളിൽ അല്ലാതെ പുറത്തൊരു ജീവിതം തന്നെ ഇല്ല എന്നുള്ളൊരു അവസ്ഥയാണ് ഈ പ്രായത്തില്. അമ്മമാരുടെ അടുത്തോ കുടുംബത്തിലുള്ളവരോടോ ഉള്ള അന്ന് വരെയുള്ള സ്നേഹവും ആ ഒരു അറ്റാച്ച്മെന്റും ഒക്കെ കുറച്ച് കുറഞ്ഞതായിട്ട് നമുക്ക് തോന്നാം. നമുക്കത് വളരെ ഹേർട്ട് ആകാം. പക്ഷെ ആദ്യം മനസ്സിലാക്കേണ്ടത് ഇത് ഒരു ഫിസിയോളജിക്കൽ കാര്യമാണ്. നമ്മളെല്ലാം ഇത്രയും അല്ലെങ്കിലും ഇതുപോലെ ചില ഒരു വേറൊരു ചെറിയ അളവ് വരെയെങ്കിലും നമ്മളൊക്കെ ഇത് പ്രകടമാക്കിയിട്ടുണ്ട്. അപ്പോ സമയത്ത് നമ്മൾ അറിയേണ്ടത് നോർമൽ പ്യൂബർട്ടി ഉണ്ടാകുന്ന സമയമാണ്. അത് കാരണമാണ് ആ പടത്തിൽ കണ്ട മാതിരിയുള്ള ആ ഒരു അവസ്ഥയിൽ അവർ ചെന്നെത്തുന്നത്. അവരെ പറഞ്ഞിട്ട് കാര്യമില്ല. സോ അതൊരു ട്രാൻസിഷൻ പീരീഡ് ആണ്. ഒരു ചൈൽഡിൽ നിന്ന് സെക്ഷൽ ആൻഡ് റീപ്രൊഡക്റ്റീവ് മെച്യൂരിറ്റിയിലോട്ട് പോകുന്ന ഒരു സ്റ്റേജ് ആണ്. ബട്ട് ഇറ്റ് ഡസ് നോട്ട് നെസസറിലി ട്രാൻസ്ലേറ്റ് ഇൻ ടു ഇമോഷണൽ മെച്യൂരിറ്റി. അതാണ് ആ സ്റ്റേജിന്റെ ഒരു ഡേഞ്ചർ. ഹോർമോണുകൾ കൊണ്ടും വളർച്ച കൊണ്ടും പ്രകടമാകുന്ന ഒരു ചേഞ്ച് അവരുടെ ഇമോഷൻസിൽ ആ ഒരു മെച്യൂരിറ്റി വരണം എന്നില്ല. റൈറ്റ്. സോ ഇവിടെ കുറച്ച് സ്ലൈഡ്സ് ഉണ്ട്. അതില് കുറച്ച് നിങ്ങൾക്ക് അത് ബോറിംഗ് ആയിട്ട് തോന്നാം. ഇതില് എനിക്ക് ജസ്റ്റ് ഇത്രയും പോയിന്റ്സേ പറയാനുള്ളൂ. കുഞ്ഞ് യൂട്രസിനകത്തുനിന്ന് പുറത്ത് വന്ന് ഈ പ്യൂബർട്ടിയുടെ സ്റ്റേജസ് തുടങ്ങുന്നത് വരെ നമ്മുടെ ഹൈപ്പോതലാമസിൽ നിന്ന് ഒരു ഇൻഹിബിറ്ററി ഇൻഫ്ലുവൻസ് ഉണ്ട്. അത് കൃത്യമായിട്ട് എന്താണ് എന്ന് ചോദിച്ചാൽ ഇതുവരെയും ഒരു സിംഗിൾ കാൻഡിഡേറ്റ് ഹോർമോണോ പെപ്റ്റൈഡോ പറയാനില്ല. പക്ഷെ ഗാബ, ന്യൂറോപെപ്റ്റൈഡ് വൈ എന്നൊക്കെ പറഞ്ഞുള്ള ചില chemical agents are believed to suppress the hypothalamus and the pituitary until the changes of puberty start. So puberty ക്ക് സമയമായി എന്ന് എങ്ങനെ ഒരു സ്വിച്ച് ഇട്ടൊന്നും അല്ല, അതൊരു ചേഞ്ച് ആണ്. അതിനും ഒരു ഒറ്റയ്ക്കൊരു കാരണം സ്വിച്ച് ഇട്ടാൽ പ്യൂബർട്ടി തുടങ്ങും എന്ന് പറയാനും പറ്റത്തില്ല. അപ്പോ ശരിക്കും പറഞ്ഞാൽ ടോട്ടലി നമുക്ക് നോൺ അല്ല എങ്ങനെയാ പ്യൂബർട്ടി തുടങ്ങുന്നത്. പക്ഷെ ഒരുപാട് കാര്യങ്ങൾ അതിൽ ഇൻഫ്ലുവൻസ് ചെയ്യുന്നു. ജെനറ്റിക്കലി, എൻവയൺമെന്റൽ കാര്യങ്ങളുണ്ട്. കുട്ടികൾ ഹലോ
Ma'am, everyone is asking because they prefer to be it is in English.
Oh, right. Oh, okay. I thought because one of the speakers actually spoke in Malayalam, so that is when I changed my plan.
Sorry, ma'am.
No, it's fine. It's absolutely fine. So, where do you want me to start from again, or is there any problem?
No, ma'am. Please continue.
Right. So what I wanted to say is there is no single button that you can switch on and say that puberty has started or it's time for puberty to start. We really do not know, but there are different factors converging to start the initiation of puberty. This can include genetic factors, environmental factors, as well as the development of the child till then. One of the age-old theories is the amount of fat deposited in the body. So this is quite an old theory, but it is not totally untrue. So there is a relation to the fat content of the body. It's believed that at least 17% of body weight should be fat for the initiation of puberty, and at least 22% of the body weight should be fat for the smooth continuation of puberty. Hope that's clear. So you might have noticed that very thin, athletic girls get pubertal changes quite late when compared to more fatter or more obese girls. And I think you might also have heard of a hormone called leptin, which is produced from the body fat, which is now understood to play a major role in the initiation of puberty. This is actually produced from body fat. So the gonadostat, or the inhibitory influence on the hypothalamus, is slowly released and it wanes off, and now the pituitary starts to act. So the hormones that are produced from the pituitary include the follicle stimulating hormone and the luteinizing hormone, which are quite familiar to all science students, I believe. And this leads on to the production of estrogen from the ovaries. So please remember that for the first couple of years, the initial first and the second year, the hypothalamo-pituitary ovarian axis, including the adrenal, this chain is actually quite immature. So by immature, we mean that it takes some time for the orchestra to start functioning properly. So it cannot play a symphony right from day one without hitch. So it needs some time, and which is why it is quite okay or quite common to see irregular periods in the first 1 to 2 years after puberty. So you have to give time. This is physiology, and it's quite physiological to have this irregularity in periods for up to 2 years following menarche. Now, once puberty, I hope all of you know that menarche is actually only the culmination of all the changes of puberty. It is not the be all and end all of puberty. It's only a part of puberty. So there is a whole lot of other changes, starting with breast development, development of axillary and pubic hair, growth spurt, development of the body and the organs in general, followed by menarche. So what is the age of onset of puberty? As all of you know, girl children tend to develop pubertal changes a couple of years earlier than boys. And what is the usual sequence? In girls, you have a growth spurt at around 9.6, between 9 and 10 years, followed by breast development. The mean is around 10 to 11, pubic and axillary hair by around 11, followed by a peak growth velocity, and finally menarche at around 12 to 13 years. All textbooks still say that the average age of menarche is between 12 and 13 for all girls worldwide, though by observation we do find that it has come down quite a bit. Remember, the changes of puberty actually span over 3 to 4 years or even more. Menarche is otherwise the breast development, and it is perhaps the first visible change of puberty for the common man, and it is induced by estrogen. It starts at around 10 to 11 years, and this is the Tanner staging of breast development, which starts from a prepubertal breast to a breast bud, followed by slight enlargement of the areola and the breast, followed by an even further development with the secondary mount, and finally the adult stage of development. This is important to know because a lot of children are quite bothered about the size of their breasts. In fact, we do have the occasional mother bringing her girl child to us with complaints of either too much or too little. So please do remember that there are genetic variations with the size and development of breasts, but roughly there are 5 stages, and you cannot expect a stage 4 or a stage 5 Tanner size breast in a teenager always. So these are the stages that I just mentioned, with stage 1, 2, 3, 4, and 5. So this can take up to 5 to 6 years for development. So also the axillary and the pubic hair starts from the prepubertal to the mature adult female. Right. So I will skip these because these are a bit too theoretical. I hope the message of puberty is clear. Now, as far as ovulation is concerned, as I mentioned, the first couple of years may not show regular cycles with regular ovulation because of this immaturity of the hypothalamo-pituitary axis. So it might be an irregular cycle because she's not ovulating properly, and that is fine. As long as she is not bleeding too heavily. So I will tell you in a nutshell that if you're ovulating regularly, you tend to have regular menstrual cycles, right? But if you're not ovulating, then your cycles comes once in around 2 to 3 months, and the bleeding tends to be heavier. Because you have not ovulated properly, there is no progesterone. So there is no withdrawal bleeding, and the bleeding that comes after just proliferation and estrogenic influence is heavier and more irregular than a regular ovulatory cycle. So we do get children who have just started to menstruate coming with very irregular cycles. That's fine, we reassure them, but we do need to prescribe iron for them, and if they're bleeding very heavily, we may be forced to give them hormones. So it's not just the external genitalia, but also the internal genitalia, including the uterus, the ovaries, and the cervix, which undergo changes during or after pubertal changes. So until the puberty occurs, as we mentioned, is not cornified, there is no estrogen, there are no bacilli producing adequate acid, lactic acid, which is essential for the maintenance of the acidic pH of the vagina. This is very important because the pH protects against most organisms, and it's very important for the cornification of the vaginal epithelium, which again is a protective mechanism. Right. Right. So we are done with the theory, which can be a bit boring. So now we come to the usual menstrual problems. I mentioned the physiology and the puberty because it's important to have a general knowledge regarding this, right? So what are the menstrual and reproductive tract problems that we encounter in this age group, that is the young adult? It is very important for either the mother, if she's educated enough or is working in the health field, or for a learned person in this field to educate this girl child about ovulation, menstruation, menstrual hygiene, and the probable menstrual problems that she should report. So I believe it's all taught to a good extent in schools these days, which is quite good. And most schools do have a lot of health counseling. We also do counseling for college students as part of SSGP. I'm not sure if your college has it, but it's quite a good initiative by the Kerala University of Health Sciences. Right. So this slide is very important for all ladies as well as men. I do believe that the men in the house should have a general knowledge about menstruation and ovulation, and it is not just the woman who should know. So what do you call normal? To say that menses or her periods are normal, it should have a regular frequency, duration, and quantity. Now, by frequency, we say that no two women can have or need have the exact same frequency, duration, or the amount lost. So it is unique to each woman. It can stretch from anywhere between 21 to 35. Textbooks now say 24 to 38, that's fine, as long as that is her usual pattern. 2 to up to 8 days flow is also normal. We have people coming saying, I only bleed for 2 days. Well, that's fine. As long as there is enough blood lost, 2 days is fine. 8 days is also fine. But more than that, well, that requires evaluation. The average blood lost in each menstrual cycle will be about 35, up to 50 mils. Up to 50 mils. Anything more than 80 mils is considered abnormal. So how do you know? We're not measuring any blood loss, are we? No. So how do you know that you're losing more than 80? The clues are you find large clots. You find large 1 to 1.5 inches size or more clots in your menstrual blood. You're through the sites, you need to keep on changing pads every few hours. You're forced to get up at night to change pads. All that is abnormal. So you need to have yourself evaluated. It is also normal to have a mild to moderate degree of dysmenorrhea. Dysmenorrhea is nothing but pain during menses. And what is PMS? Any idea? It's nothing but premenstrual syndrome. So it is also normal to have some degree of premenstrual syndrome. I think I have a slide on it, and I will come to that. Now, this is a self-screening questionnaire that we prepared for the SSGP, and it's used by the Kerala University of Health Sciences, and it's quite useful. I have just taken the questionnaire, a part of the questionnaire which is important when you suspect menstrual problems among girls. So these are the questions that you need to be asking yourself. Is the frequency of menstrual periods that you have less than 21 or more than 35 days? Is your menstrual flow lesser than 2 days or more than 8 days? Do you have severe lower abdominal pain with nausea, vomiting, or any other discomfort during menses? With sickness absenteeism at school or college exceeding 35%. If it's a positive answer to one or more of these, then she needs to be evaluated by a gynecologist. So what are the common menstrual problems that can happen in this age? Absent menses. She has not menstruated ever. It's called primary amenorrhea. Scanty bleeding is hypomenorrhea. Excessive bleeding is menorrhagia. Frequent menses. She happens to have frequent cycles come in less than every 21 days. It's polymenorrhea. Fewer cycles is oligomenorrhea. Painful menses, very severe painful menses is dysmenorrhea, and severe forms of premenstrual syndrome. In a survey done in our population, it was found that 21% of girls had menstrual disorders to a varying extent, and majority of them had dysmenorrhea or painful periods. About 10 to 12% had oligomenorrhea, which is very few cycles. So in this context, we should know that there is something very rare but called primary amenorrhea, where a girl child never menstruates. So how long should you wait to label it as primary amenorrhea? If she has no pubertal changes, no breast development, no axillary or pubic hair, no growth spurt, and she has of course not menstruated, then you have to evaluate her before she or after she turns 13. We used to say 14, but now we brought the cut off to 13. And if she has pubertal changes, then you can wait till the child is 15 to 16. What is secondary amenorrhea? This girl or woman has been having regular cycles, but for the last 6 months, she has not had any periods. Then you call it secondary amenorrhea. So what are the causes of primary amenorrhea? First of all, let me tell you that it is very upsetting psychologically to both the girl child and her family that she's not attaining periods. But remember, in majority of the cases, it's only a constitutional problem which runs in the family. The mother or the siblings tend to have menstruation or menarche later. But that is a diagnosis of exclusion. You have to actually evaluate and rule out all other causes before you label it as constitutional or physiological. So what are the more pathological causes? One is genetic causes like Turner syndrome or an androgen insensitivity syndrome. It could be birth defects affecting the vagina or the uterus. It could be hormonal, endocrinological disorders. Now, this is a very common cause of, it's not a very common cause, but it is a very simple cause of primary amenorrhea, where everything is normal. The child has developed well into puberty. She's having cyclical abdominal pain, but the blood is not coming out. Why? Because she has what is called an imperforate hymen, right? Her hymen should have a hole in it, but this is closed. So the blood is collecting inside the vagina and the uterus. It has to be incised. So it's a very small operation done under anesthesia, and you drain the blood, and that's it. But there are more pathological causes for primary amenorrhea where you may not be able to help much, like Turner syndrome, where the defect is in the karyotype. So she does not have a proper normal female karyotype of 46XX. So she tends to have other stigmata, as you might have learned in school, and she has very infantile sexual development. And ovaries are also defective, so she does not have any hormonal support or development of the external genitalia. When you detect Turner syndrome, you can give her hormone replacement therapy, which causes withdrawal bleeding, but this is not true menstrual periods, and they cannot usually conceive, especially complete Turner syndromes cannot conceive because they do not have proper oocytes. They will need to adopt or go for donor ovum. Donor ovum, right. Androgen insensitivity syndrome is another condition that you need to know or just be aware of, where the girl looks totally attractive, tall, with well-developed breasts, scanty axillary and pubic hair, but she never menstruates. Why? Why? Because her karyotype is actually 46XY, which means she's actually a male, but due to some problems in her testosterone receptor, androgen receptor, the testosterone is not exerting its effect. And this can also be quite emotionally upsetting to break the news to her and her family that this is actually a male.
Well,
Hello?
Sheila, please mute. Sheila, Achu, please mute.
Right. So there is also another condition called Mayer-Rokitansky syndrome in one child in the last outpatient clinic, where this child was brought with primary amenorrhea, and on examination she looked totally normal, like a normal girl, child, teenager, but she had a blind ending vagina. And on examination, we found that her ovaries are normal, her hormones are normal, but she does not have a vagina or a uterus. Now, these unfortunate girls will need surrogacy, but they can use oocyte because their adoption is another option. Going on to secondary amenorrhea, we have lots and lots of girls and young women coming to us with secondary amenorrhea. They were having regular cycles up until a few months ago, but now started to have irregular periods or no menstruation at all. What comes to your mind? What are the first questions that we ask? I'm sure, being science students, you're all aware of something called the polycystic ovarian disease. The conditions are thyroid problems, very important cause for irregular cycles, obesity, eating disorders, and also extreme physical activity and stress. But not don't forget the possibility of pregnancy. This is a study which was our previous University of Health Sciences. There is a strong lack of parental supervision, broken family relationship, health, and also because of non-engagement of the adolescent in any productive activity. What does this study findings show? It shows or highlights the need for family life education for younger adolescents and premarital counseling for those above 18 years. So when do we say that bleeding is excessive? When you're bleeding more than 7 to 8 days, when you need to change your pad every 1 to 2 hours, you need to get up at night to change your pads. Remember, this is physiological in both extremes of a woman's life. When she's just had her menarche, she can have menorrhagia, what you call puberty menorrhagia for the first 2 years, and also when she's about to end her periods, so a couple of years or more before her menopause. These are due to the physiological changes happening to the hypothalamo-pituitary ovarian axis. So what should you or how should you manage menstrual disorders? We reassure after evaluation. If she's anemic, we give them iron. We do not start hormones straight away. We first treat them with a combination of antifibrinolytic drugs. And so we'll go on to premenstrual syndrome. Um, uh, Let me tell you that almost 100% of women have premenstrual syndrome, but the extent and duration may vary from one woman to another. It usually starts a week before periods. Because of the changes in hormones happening, there is an increase in the extracellular body water content. So what are the symptoms that the lady can have? She can have irritability, feeling of gloom, sadness, lack of concentration, poor sleep. She has a feeling of bloatedness. She may have bowel symptoms. Remember, this is fine. Almost all women are going through varying forms of PMS. You can try exercise, yoga, aerobics, or Zumba, or whatever. Try to have a balanced diet with fruits and vegetables. Sleep hygiene. Have you all heard of this word? Food hygiene, menstrual hygiene, and sleep hygiene. So what is sleep hygiene? The word itself is self-explanatory. You go to bed early, you wake up early, right? And stop watching any screens at least an hour before you go to sleep. Try to listen to good music or read a book before you go to sleep. Fluid intake is important. Uh, Drink at least 2 liters of water per day is what we advise all our patients, not just in pregnancy, but every day of your life, unless you have a medical condition which prevents you from having it. Complementary therapies are available, but in the form of herbal medications, vitamins like vitamin B6, etc. Very rarely in women who are suffering quite a lot because of premenstrual syndrome and bloatedness, which is affecting her quality of life, you may be forced to give her mild degrees or doses of antidepressant drugs like fluoxetine. Dysmenorrhea or pain during menstrual cycles is also normal as long as it starts on the day of your periods or a couple of hours before you see the bleeding and lasts for a few days after the flow starts. That is physiological. Again, you may be forced to take medications, maybe a tablet or two. That is fine. But if you continue to have pain for days before you start your menstruation and the pain continues for a few days after you menstruate with almost no pain-free intervals, then that is abnormal and it cannot be labeled as physiological dysmenorrhea. It needs to be evaluated for secondary causes, which may be because of endometriosis, fibroids, adenomyosis, or PID. There are a lot of other conditions which can cause pathological dysmenorrhea. I have seen mothers who do not give any sort of medications to their children during dysmenorrhea, saying it's going to affect their fertility. Now, that is not scientifically right at all. In fact, it has no scientific basis because menstruation is not the time of ovulation. Ovulation happens at least 12 to 14 days after you menstruate. So there is no way or let your child. In fact, a lot of children can actually come to school and stop being absent if you just give them 1 or 2 tablets for day 1 of periods. So remember, you tend to have pain during menses because you are ovulating. The cycles, the period generally tends to be painless. So you reassure them, you give them mild antispasmodics or NSAIDs like mefenamic acid. Do advise them that it does not affect fertility. You can try home remedies, yes. But as I said, if it's too severe, you need to consult a gynecologist to rule out endometriosis. Other causes of irregular cycles are obesity. That is another important cause. Once your weight changes, remember it has an influence on your hypothalamus. We see more of obesity than anorexia. So it's usually majority of women that we come across in our outpatient clinic tend to be overweight. And it is very difficult to make them understand that it is because of their weight disparity or their excess body fat that they are having menstrual irregularities. They tend not to understand, or they tend not to grasp it. Let's say they do not grasp it. But please remember that body fat has a big influence and a strong influence on your periods, on your hormones, and on your well-being, apart from its effect on various other health problems. Of this term, endocrine disruptors? If not, you should. So endocrine disruptors are for environment, water, through food, through air. Um, Somehow it gets into your system. This environment is though textbooks used to quote a percentage of 5 to 10 between 18 and 44 years, later studies in Indian populations say 1 in 3 women are affected. Now that is alarming. It is alarming to say the least. There are girls who come to us and ask us, why me? What did I do? Well, you cannot always pin it on her lifestyle, though lifestyle does play a major role, but her genes can also have a major effect on why she's prone to develop polycystic ovarian disease, and also the race to which she belongs. Unfortunately, our race, which is the Southeast Asian race, is highly prone to polycystic ovarian disease. Remember, it can affect all age groups. How they present to us depends on the age group. Very young girls, teenagers, and young adults come complaining of irregular cycles. They hardly ever get menstruation, or they get once in like 2 or 3 months. It tends to be very heavy. There are girls with polycystic ovarian disease who get very frequent periods also, but usually as spotting only and totally irregular periods in some. There are girls who come to us because they're bothered about their pimples, excessive hair growth, blackish discoloration of their neck or their face or other areas of their body, including the axilla. Again, we have older girls or women, younger women as well coming to us because they are not conceiving, they do not have babies. Women who come with irregular cycles again, and much older women coming with varying degrees of endometrial hyperplasia. It's nothing but thickening of the mucosal lining of the uterus, which can be a forerunner, which can be a precursor of uterine cancer. Right. So when will you suspect polycystic ovarian syndrome? When the girl is overweight or obese. Remember, for Asian women, the cutoff beyond which you will say that she is overweight, or the cutoff is 23 and not 25, or the upper limit of normal BMI. I hope all of you know how to calculate your body mass index. It's weight in kilograms by height in meter square. And I want all of you to calculate your BMI today and see if you fall within the normal. Remember, 23 is the upper limit for Asians and not 25, which is for Westerners. Inspect whether you have black discoloration around your neck or axilla. Check whether you have a normal menstrual pattern as I have described earlier. Do you have increased hair growth, excessive acne or pimples? Pimples are normal, but when it is excessive, it is abnormal. So there are various criteria for the doctor or the gynecologist to say that she has polycystic ovarian syndrome. Now, all the body features and habitus that I described only come under clinical hyperandrogenemia. And that is not the only criteria to say that she has polycystic ovarian syndrome. She needs to have all three, which is features of hyperandrogenism with ovarian dysfunction in the form of irregular cycles, with ultrasound evidence of polycystic ovarian syndrome. I remember girls with polycystic ovarian syndrome or people who look like they are having PCOD may not be having PCOD. You need to rule out other causes like thyroid dysfunction, prolactin, and other endocrinological disorders, adrenal tumors. Right. So these are the 4 questions which can diagnose polycystic ovarian syndrome with a sensitivity of 77 and a specificity of 93%. So a proper focused history, asking about the menstrual pattern, her weight gain, her present weight, excessive hair growth, and acne. Now this is what we call hirsutism, right? Male pattern. This is acanthosis nigricans, blackish velvety appearance of her neck, seborrheic dermatitis and acne. Now this is abnormal. This is quite abnormal. And this is the chart that I mentioned. So up to 22.9 or 23 is the normal cutoff, right? Anything beyond 23 is overweight, pre-obese, obese is beyond 30, and then it goes on to morbid obesity. There is also another terminology called waist to hip ratio, which you should be aware of. The female waist to hip ratio, which is considered normal, is 0.8 or below. The more it increases, the more risk it is for various metabolic conditions, including coronary artery disease and dyslipidemia. Please take a look at this picture. Both these women are overweight, or let's say obese. But which is more dangerous? Any idea? Is it apple or pear? Any volunteers? Any volunteers? Which is more dangerous? Apple shape or pear shape obesity?
Apple.
Yes, it is apple because she has more truncal obesity, more central management. We all are aware of what is good, what we need to do, everything. We're all aware of what is good and what is good for us and what we need to know, what we need to do. But the difficult part is practicing it. Unfortunately, many people tend to think that the answer to polycystic ovarian disease treatment lies with the gynecologist. I'm sorry to say that the treatment is in the hands of the patient and her family. Why? Because lifestyle modification, which is the most important thing, has to be practiced by the girl, the woman, and her family needs to support her. Regular physical exercise, 30 minutes of moderately intense exercise, 3 days a week, if she's not obese. But if she's obese, an hour a day. Is it enough that you exercise alone? No, you need to take a low
Ma'am,
I don't know what we're doing. We only need to, we need to eat to live and not live to eat, right? And why we stress on weight loss is, as we mentioned, the body fat has a major role to play in hormones. Even if you lose 5 to 10% of body fat and weight, it causes a decrease in testosterone with an increase in SHBG, which resumes menses on its own spontaneously, and you start ovulating. If you want to conceive, you need to lose weight and to maintain it. So it depends on your discipline and not on the doctor. It's very easy for a gynecologist to write some hormonal pills that you need to take 21 or 24 days, and you tend to have regular periods. But that is not true periods. It's only artificially created withdrawal bleeding after giving exogenous hormones. It is not your normal natural period. Periods should happen on its own. It shouldn't need external manipulation. So if you need to have spontaneous natural cycles, you need to reduce or correct your hormonal profile on your own. So exercise is very important. It improves strength and endurance and builds healthy bone and muscles. It reduces anxiety and stress, increases self-esteem. How much? I've already mentioned. You can choose between walking, skipping, swimming, weightlifting. It's up to you. Whatever you do, you need to reduce your weight. Please be aware of the food pyramid. For Malayalis, it tends to be the other way around. We tend to eat so much of fat, saturated fats. Now, Mediterranean diet is claimed to be one of the best diets that a human being can have. Unfortunately, most of the stuff seen in this picture is on the costlier side for us, including olive oil and all these dry fruits and nuts tend to be costly. Pears, again, papaya is freely available, but again, it's not available round the year, all round the year. But right, take a look at all this fish. And so these are believed to be rich in PUFA, polyunsaturated fatty acids. So increased stress, excessive eating of junk foods, and lack of exercise contributes to a vicious cycle of a lifestyle-related disease leading to polycystic ovarian syndrome. Remember, hormonal treatment and laparoscopy is not the number one treatment. It is lifestyle modification and discipline. So we have various treatments, just mentioning about metformin. So metformin is a drug that you give for diabetics. We have people who are very concerned and they come and ask us, Doctor, isn't this an anti-diabetic drug? Yes, it is. But because insulin is playing an important role in the pathogenesis of polycystic ovarian disease, it is the same drug that you give for both polycystic ovarian syndrome and diabetes. And don't worry, you're not going to have low blood sugars. A lot psychologically. Right, so this is just a laparoscopic picture of polycystic ovarian disease. These are the white, bulky ovaries, which are usually drilled. So you put about 4 holes in each ovary, and it's believed to reduce or normalize the excessive hormones to some extent. Now, this slide is very important. I want all of you to understand that polycystic ovarian syndrome is not just, or it does not begin or end with menstrual problems or a failure to have babies. It has a lot of long-term consequences. It can affect your heart, it can give you diabetes, it can give you cancers, it can affect your mood, it can produce sleep apnea, hepatitis, whatnot. So you have to understand that you have a major role in preventing the consequences of polycystic ovarian syndrome, and it's up to you. So these are the health consequences. Going on to reproductive tract infection, women come with urinary tract infection, vaginitis, cervicitis, pelvic inflammatory disease. Leukorrhea is nothing but excessive white discharge. Remember, white discharge is normal during different phases of the menstrual cycle. For a week before you have your periods and during the second week, which is say from about 9 to 10 days onwards after your first day of periods, it's okay to have excessive or increased vaginal discharge. This is because of the hormone that is happening. Saying this because many mothers and girls believe that they have some infection and that is why they are having this white discharge. That is not true. So if you are going on having excessive white discharge throughout the menstrual cycle, every day you're forced to vaginas, it's sweating your panties, it's affecting you, it's colored yellow or any other color, it's itchy, it's foul smelling, then it's abnormal and you need to consult a gynecologist. It's not just hygiene, but various other reasons. The common reasons are, so do not think that infection is the only cause for excessive discharge. That is the message I want to convey. In fact, non-infectious causes are more common than infectious causes. It could be synthetic pads, sanitary pads, colored undergarments because of the dyes used to color the garments, perfumes, soaps, detergents, fabric softeners, feminine hygiene products that are advertised on TV and magazines and which you buy over the counter. All these can actually irritate the skin in some way. Sanitary pads. What is shown on TV is it's convenient, thin, it has wings, it doesn't move, it's leak-proof, hygienic. But what is the reality? It's made of plastics and chemicals. It causes infection and rashes. It's associated with health problems. It makes menstrual blood smell. Normal menstrual blood does not smell, but when it collects in the pads for some time, it starts smelling. Remember, most of the pads are non-biodegradable and it cannot be reused. These are some new information that I got recently, maybe a couple of years ago. I came to know that a disposable pad has things like styrene, chloromethane, acetone, and chloroethane, which are used in various chemical industries. So problems faced when using pads and tampons, it causes chafing of the skin, it can produce urinary infection, it can cause what is called bacterial vaginosis, which is it alters the normal bacterial vaginal flora. It can cause contact dermatitis and discoloration of the vulva or the perineum. It can cause malodor. It can cause leak, dryness in the vagina, and other infections. A word on cloth pads. So something which was used by older generations is actually coming back. In fact, the good thing about it is you can reuse, and it can be even more hygienic than your sanitary pads, because what we've seen is most girls or women who use these expensive sanitary pads with chemical agents like gel form and all that, which absorbs the menstrual blood, and they do not feel wet. So what they do is they walk around with the pad for hours before they change it. Whereas when you use cloth pads, you tend to change it more often, which is more hygienic. How do you use it? You only need to soak it in cold water for at least 30 minutes and scrub softly with a mild detergent and dry it in natural sunlight. Now, menstrual cups are for women who have started sexual activity, and there are various sizes available. It's available online on Amazon. It costs only about 200 to 300. You have to use by trial and error to find the right size for you. Remember, you may not see lots of advertisements on menstrual cups. This is because when you buy one, it's made of silicone and it lasts for a minimum of 10 years if you use it properly. So companies do not make much profit. So they are naturally not going to advertise it too much. But remember, menstrual cups are healthier, they're greener for the environment, they're completely safe. Remember, they are made of materials similar to feeding bottle nipples, with medical grade materials like silicone or TPE. They collect menstrual blood, they do not absorb it. So you will need to use it, and you yourself can decide when it becomes full, because flow differs from person to person, and you can go and just discard it, wash it, and reuse it after the menstrual cycle. So you only need to have 1 or 2 cups. You don't need to sterilize it. You shouldn't actually boil it. And what they say is you don't even need to use soap to wash it. You only need to clean it with running water. So from menarche to marriage or to onset of sexual activity, you can choose cloth pads, and from then onwards to menopause, menstrual cup is a good option. So use a menstrual cup or a cloth pad and say hello to trash-free, rash-free, cash-free parents. Now this is one of the slogans of FOGSI, which is the Federation of OBG Specialists of India. Vulvovaginitis is only a less common cause for discharge. And the usual things that we find are candidal infection, which is a fungal infection, bacterial vaginosis, which is not strictly an infection, but it is an alteration of the bacterial flora of the vagina, and trichomoniasis. It can also be because of infections of the cervix by chlamydia or gonococci. Candida, as all of you know, is a yeast. It can be present elsewhere on skin, mouth, and genitalia. It can occur in women who are predisposed to it because of their low immunity, and also because of moist environment, humid. 1 in 10 girls are believed to have candidiasis. How do you prevent it? Genital hygiene. Change undergarment twice. Use loose cotton, light colored, because darker dyes used tend to produce dermatitis and irritation. Change pads at least 4 to 5 hourly. In schools also, it's best to dispense sanitary pads and avoid excess soap, chemicals, and deodorants, and keep the area dry. What we advise girls and mothers is, when you're at home, it is not absolutely essential to wear tight fitting or even loose fitting undergarments. Yes, there is treatment for candidiasis in the form of oral and local application. Bacterial vaginosis can happen rarely in unmarried girls. It's because of a predominance of anaerobic bacteria, which replace the usual lactobacillus. It produces a fishy odor and the discharge is grayish white. We can take swabs for examination under the microscope and find pathognomonic features like clue cells, and you can do the KOH test and everything and treat bacterial vaginosis with metronidazole. Trichomoniasis vaginalis, another protozoan parasite, can produce frothy green malodorous profuse discharge with pruritus. Again, you can confirm with direct cell line microscopy. You find motile trichomonads. As I mentioned, suspect sexual abuse in prepubertal girls. So menstrual hygiene is more important than general hygiene. Do you agree? To prevent reproductive tract infections, it can affect fertility and reproduction, not only during menses, but also on a daily basis. Menstrual hygiene is very important. Trim the hair around the genitalia just prior to menstruation. Shaving or using hair removers are not generally recommended because it tends to cause minute abrasions on the skin. It can cause bacterial infection. Right. Come on to the reproductive age, you find a lot of problems, just like we mentioned, menstrual problems, reproductive infections, sexual issues, fertility issues, antenatal problems, and pregnancy problems. Now, the cause for the menstrual problems can vary in this age group. We were talking about young adults till now, but now we come on to the reproductive age women. The causes of menstrual problems can now become more of structural causes like fibroids, adenomyosis, or endometriosis. Of course, they can also have polycystic ovarian disease, obesity, or thyroid problems. We should rule out pregnancy, of course. A word about fibroids. They're the commonest benign tumor of the uterus. As much as 30 to 45% of women in the age group of 25 to 45, it's 25 to 45-year age group, can have 1 or 2 tiny fibroids on ultrasound scanning. It does not mean that she should have it removed. If it is asymptomatic, not producing any problems, it can be followed up. I am stressing on this because we do find people coming to us for a second opinion because some hospital or the other has advised that a 1 or 2 centimeter tiny fibroid not producing any problem needs to be removed laparoscopically or otherwise. So always kindly get a second opinion before you jump to unnecessary surgeries. Having said that, fibroids are the most common cause for hysterectomies or myomectomies, of course. Myomectomy is just an operation that you do for removal of fibroids. There are various risk factors. People who tend to have more of estrogen tend to have more of fibroids. Weight reduction and lifestyle modification is important in prevention, but it's not always preventable. You can have various sites of fibroids as is evident from the picture. Remember, this kind of fibroids which are away from the uterus, and if it is small, does not produce menstrual problems and may be left as such unless it is too large or producing problems due to twisting. Remember, almost half of fibroids may not have any symptoms, but others may come to you with menstrual problems or pressure symptoms. We generally do a clinical examination followed by ultrasound examination to confirm, and then depending on the site, size, and number of fibroids, we choose various modalities of treatment. Yes, there are medications to decrease the size of fibroids, but the problem with medical management is it cannot cause fibroids to disappear, and moreover, it cannot be had for more than 6 months at a time. And once you stop medications, these fibroids tend to recur. So surgery, again, various options. You can open up, you can do vaginally, you can do abdominally, you can use laparoscopic or hysteroscopic methods to remove fibroids. Right. This is a message that all of you should take from this class. All tumors are not cancer, but to reach this conclusion, you need to evaluate the patient properly. Going on to pregnancy problems, I will mention a few problems that one needs to know about pregnancy. Why? Because yes, the general public needs to have a knowledge regarding the same. And when you know about possible complications that can happen, even in a so-called low-risk woman, you will tend to understand what the doctor is trying to tell you, right? And you will be more receptive. So hyperemesis is excessive vomiting requiring hospitalization with fluids. Urinary tract infections tend to be more common. You need to have at least 2 liters of fluid, and you need to go to to void urine more often in pregnancy. Bleeding and pain in first trimester of pregnancy, which is up to the 3rd month of pregnancy, may be because of miscarriage or abortion. It may be because of molar pregnancy, which in Malayalam we call as Mundirikola Garbham. But a very important cause that has to be ruled out, that has to be detected and treated early is ectopic pregnancy, because if it is an ectopic pregnancy, it can cause death of the mother. 2nd trimester, again, it can be bleeding because of miscarriage, urinary infections. The fluid in the uterus can leak early. She can go into preterm delivery. She can have anemia, diabetes, or hypertension in pregnancy. Hypertension in pregnancy is a very important serious complication. Unlike, it is not in any way related to the hypertension that you see in non-pregnant women or men. This is entirely because of pregnancy-related changes, and it has an important effect on the mother and the child. So it is a high-risk pregnancy if she becomes hypertensive or diabetic in pregnancy. Third trimester also, you can have any of these problems, including growth problems of the child, less amniotic fluid or more amniotic fluid, labor not starting even after dates, requiring medications to start off labor. Now, a woman who is totally low risk has entered labor, but she can have any of these conditions. Until then, she was low risk. The relatives were totally under the impression that nothing could go wrong. But these are the possible things that can happen even to a low risk woman during labor. So that is why we say that obstetrics is a dangerous ball game, and a low risk woman can become high risk um, at any time in labor. So abruption, it is a very dangerous condition where the placenta separates even before the child comes out. It can cause death of not just the baby, but it can cause bleeding, which can endanger the life of the mother. Rupture uterus, the uterus can give way. Again, a very dangerous condition. Cord prolapse is pukkulkudi പുറത്തോട്ട് വരിക. It can cause death of the child if not detected. Fetal distress, the child can develop heart problems, respiration problems during labor, requiring emergency cesarean section. Prolonged labor, it's taking a long time for the cervix to dilate and the child to come out. Instrumental deliveries requiring forceps or vacuum to deliver the child, or emergency cesarean delivery. Even after delivery, the mother can have serious complications like bleeding, breathing problems due to amniotic fluid embolism. She can throw fits or seizures because of high blood pressures. She can have other problems like blood clots in her lungs. Again, lactation problems. Breastfeeding problems are a major issue that we come across, where the relatives and mothers tend to always complain that there is not enough milk for the child, which is usually not the cause. It takes about 1 to 3 days for the milk to flow properly. And the colostrum, or the clear fluid or the yellowy discharge which comes until that time, should not be discarded and should be given to the child. So frequent feeds on demand, maybe it's the dictum. Urinary infections, wound infections for the episiotomy or the cesarean sites, psychosocial issues. This is a time of rapid emotional turbulence and changes. So the mother, the pregnant, the delivered lady needs emotional support from her relatives and friends. She needs to continue her iron and calcium tablets, iron for at least 3 months post-delivery, and calcium should be continued and stopped only after she stops breastfeeding, because otherwise her bones tend to become very weak. Now we go on to the period just before menopause, which is the perimenopausal period. Now this is very similar to the time of pre-puberty or just after puberty. Why? Because again, the HPO axis, the hypothalamo-pituitary ovarian axis, is becoming immature or dysfunctional. It tends to lose its rhythm once more. So it manifests as irregular cycles, not ovulating regularly. The periods come once in a while. It tends to be heavy. It doesn't follow any regular rhythmic pattern. She can have psychosexual problems. And the most important thing for the gynecologist is to rule out cancer in this age group and in menopausal age group. So apart from ultrasound scans, we might do curettage, what we call in layman's terms, we say DNC. So we will be forced to take biopsies from the lining of the uterus. Now, what is menopause? Menopause is actually a retrospective diagnosis. You cannot say today that a woman who had a cycle 2 months back had her final menstrual period then. You can only say that that was her final menstrual period after at least 1 year has lapsed. What is the average age of menopause in India? It tends to be about 47 years, but affluent societies in India have an age of menopause at around 51 to 52 years, just like Western societies. Only once she has stopped menstruating for at least 1 year can you label her as having had menopause. But having said that, in this age group, if a woman does not have bleeding for 6 months and then starts bleeding again, she should be evaluated. Of course, any postmenopausal bleeding, even if it's only a spot of blood, should be evaluated. I want to stress this point because we have women coming to us after ignoring warning bleeds, thinking it's normal, but once they report late, they would already have advanced forms of some pathology. Remember, the most common cause for postmenopausal bleeding is simple atrophic endometritis. Why? What is it? It is just low estrogens producing thinning of the mucosal lining, making it prone to bleed. But you cannot assume that just because it is the most common cause, that is the cause in this lady. You have to evaluate with an ultrasound, probably thyroid function test, diabetic screening. You will need to do a pap smear. What is a pap smear? It's nothing but a cervical cancer screening test. And if needed, she might need biopsies from the cervix and endometrial biopsies. So please remember, any postmenopausal bleeding or spotting should be evaluated by the gynecologist. Now, postmenopausal period is a time for mood swings, hot flushes, psychosexual issues due to atrophy, urogenital symptoms. She can have painful urination, sex becomes painful, she can have, it can upset her mental well-being and harmony at home. And our Indian women um, uh, do not tend to complain too much, but uh, there is help if they need it. So postmenopausal discharge, bleeding, abdominal distension, irritable bowel syndromes of new or recent onset should also not be ignored. Why do we say that prevention is better than cure? Because there are some cancers which can be prevented. In gynecology, one such is cervical cancer. But other cancers like the uterine or the ovarian cancers may not be always preventable. So what then is the next option? If you cannot prevent it, at least report early so that we can detect early and it may be fully curable. So what are the risk factors for cancers in general. In gynecology, as in any other specialty, genetics plays an important role in at least 5 to 10% of women. They have unfortunately inherited some genes which make them prone to either breast, endometrial, or ovarian cancers. Cervical cancers very rarely are genetic. Environmental causes, yes. Age is a very important non-modifiable risk factor for cancer. The older you become, the lesser your DNA repair mechanisms work, which make you prone to develop malignancies. Obesity, fat is dangerous, not just for benign conditions, but also for cancers. Parity, which means എത്ര കുട്ടികളുണ്ട്. So the lesser children or no children women tend to have a higher level of estrogenic exposure in their lifetime, which make them prone to malignancies of the breast, the uterus, and probably also the ovaries. But cervical cancers tend to happen more in women who have started their sexual life earlier and have delivered repeatedly multiple times. Virus. So viral pathology or etiology for cancer is most relevant for cervical cancer. And I'm sure all of you know the virus which causes cervical cancer. It is, has everyone gone to sleep, or does anyone want to volunteer?
Papilloma.
Yes,
Papilloma
correct.
virus.
Exactly. So it is a human papilloma virus, which is believed to be the etiological agent for 99% of cervical cancers. But none of the other cancers in gynecology are believed to be viral. They are usually related to hormones. Now, what are the warning signs that you should look out for? If you have irregular bleeding and you are nearing menopause, if you have completed your menopause and now started to have bleeding or spotting, you are bleeding after sexual intercourse, you have abnormal discharge, you have a change in bowel patterns, weight loss, loss of appetite, bloating phenomenon, and early satiety with food, loss of appetite, all these should not be ignored. So as we mentioned, HPV is the agent which causes cancer cervix, and various subtypes of the virus, but most important are 16, 18, 31, and 33. Now, the present vaccine available is a non-valent vaccine, which means it's active against 9 of the most common subtypes of HPV. And up until now, it used to be the quadrivalent vaccine. What is the ideal time to give it? It is before sexual activity. And generally, it is given at between 11 to 12 years in schoolgirls. And if the child is below 15, a single dose is enough. But after 15 and up to 26 years, you need to give at least 2 doses. It is unfortunately not yet a part of the school health or universal immunization program in India, but it's already a part of the school health program and free immunization schedule in various countries like England, Australia, and Germany. Its safety has been established, and the reason why we are promoting HPV vaccine is it will reduce more than 2/3 of cancer cervix and more than 50% of other cancers due to HPV. So HPV does not produce only cervical cancers. It produces cancers of the oral mucosa, the pharyngeal mucosa, It also causes cancers in men. So if you vaccinate all your girls, the men or the boys also are believed to get herd immunity. So this is just a pictorial representation of how the cervix of a normal woman or a normal cervix looks like. When we put in a speculum and examine, this is what we see. Now, these are the early changes, which is advanced and become quite advanced. It has spread out of the cervix into the parametrium and the vagina. Now, I want all of you to know this term, pap smear. Papinicola smear or pap smear is nothing but a scraping from the cervix, right? This is pap smear, and this is a spatula that we use to scrape some cells. This can be done in the outpatient clinic. It does not require anesthesia, or you don't need to be taken to the operation theater to do this. It's a simple outpatient procedure where the cells that you get are smeared on a glass slide and fixed in a fixative and examined by the pathologist. For what? For atypical or abnormal cells, which may be the precursor of malignancy or cancer. The good thing about cervical cancer is it has a definite viral etiology. So you can prevent it to a major extent by vaccination. But if you are not in the younger generation and you have already reached your middle age or beyond that, what you can do is detect early stages before the cancer has developed. That is one good thing about cancer cervix. It tends to have a long latent period. So you can detect atypical cells before the cancer starts. How? By doing regular pap smears. One question that we get is it enough to do one pap smear? I have done one pap smear, so I don't need to do anymore. No, that is absolutely wrong. One pap smear can probably detect only about 50 to 60%, meaning the sensitivity is only 50 to 60%. So you need to do it regularly once in at least 3 years until you're 50. And beyond 50 up to 65 years, provided all your previous smears were normal, you need to do it at least once in 5 years. I hope that's clear. Now, this is a very abnormal looking cervix. ഇത്രയും abnormal ആയിട്ട് കാണുന്ന cervixന് you don't need to do a pap smear. Pap smear is done for normal looking cervix to detect microscopic changes. Now, this is already macroscopically visible. So all that you need to do is take targeted biopsies. We do what is called a colposcopy, which is nothing but a magnified visualization of the cervix and the vagina. You can also examine external genitalia. You can apply acetic acid and take targeted biopsies. Now, these are simple procedures. Why we say to detect early is if you detect it before the cancer has happened, you could actually treat that pre-malignant phase with simple excision procedures. See, this is how it looks like after simple excision. You don't need to remove the full cervix or the full vagina, or the full uterus. But once it's late, she will require radical surgeries with or without chemotherapy and radiation. One word about uterine cancer. Again, she can present with irregular bleeding. We do ultrasounds. We detect thick endometrium. We take biopsies. See, this is how we do. This is less painful than this. This is fractional curettage, in which you use a spoon-like thing to scrape from the uterus. So it's painful, so we do it under anesthesia. Whereas this can be done, it's just aspirating with a syringe. It can be done even in the outpatient clinic, and it is not painful. So we sent for histopathology, and depending on the report, we do surgery, hysterectomy. She may need radiation after it. So depends on the stage of her disease. If it is inoperable and advanced stage, unfortunately, it cannot be removed by surgery. What about cancer ovary? This is increasing in incidence in our population. When I was a undergraduate for MBBS 2 decades back, I was taught that the incidence was around 1 in 200, but now it is 1 in 70, 1 in 70, which means, it is even more than doubled in its incidence. The unfortunate thing about CA ovary is it does not present with definite bleeding symptoms. Majority of cancer ovary does not come with menstrual problems or bleeding problems. So it tends to be silent and presents very late, unless you are very suspicious and you do an ultrasound. Ultrasound is the primary modality, because if you detect it per abdomen with a clinician or a doctor, it has to grow to big proportions, or fairly big. Whereas an ultrasound can detect even 1 to 2 centimeter size lesions with abnormal pathology or abnormal features, which cannot be detected with our hands alone. Of course, we do Doppler studies also to detect if it is abnormal. Last, we come on to breast cancer. Right. How common is it? It is the most common cancer of women worldwide, including in Kerala, where in metropolitan cities of Kerala, including Cochin and Trivandrum, um, the incidence is almost similar to the West. And majority of them actually come to the gynecologist the first time. And primary prevention versus secondary prevention is important, yes, but not all breast cancers are totally preventable, simply because, as we mentioned, 5 to 10% of women have unfortunately inherited a gene which makes them predisposed to developing breast cancer. So these are the risk factors which cannot be modified. Age, the older you become, the higher is your chance of having any cancer, including breast cancer. Heredity and gender. Females are definitely more prone. I say this because even males can have breast cancer. So what are the risk factors for breast cancer as regards to age? So the risk increases. Uh, a lifetime risk for a woman is 1 in 8. What are the modifiable risk factors? So you can decrease the intake of high dose hormones, estrogen and progesterone. Both are important in the etiopathogenesis, or hormone replacement therapy after menopause. Your diabetes, smoking and alcohol, obesity, and lifestyle are all modifiable risk factors to reduce your risk of having breast cancer. Now, these are three important modes of screening. Why do we screen? We screen to detect early, because you may not be able to prevent always, but at least you need to detect cancers early. How do you do that? You do self-examination, clinician examination, and other investigations, radiological. So you have to begin by looking at the breast in the standing posture and the lying down posture. The best time would be to under the shower when you're taking a bath at least once a month. At least once a month. So what are the warning symptoms? Painless lumps that were not there last month. You find discharge or bleeding or blood-stained discharge. change in the size or the shape of the nipple, or a change in the size, shape, or contour of the breast, new lumps or flattened areas, puckered skin, moles which have darkened or changed color. This is puckering of the skin or pudgy orange kind of appearance. This is definitely a advanced malignancy which is eroded out into the skin. Horizontal mammography. So the radiologist reports on the risk of the lump being a malignancy. Now the problem with self-examination or a doctor examining it is the hands can detect lumps of 1.5 to 2 centimeters in size, but the mammogram can detect a lump even when it is less than 0.5 centimeters, which means the breast may not be removed in its entirety. So one good thing or one advantage of detecting a very small lump in the earliest stage itself is that you can do conservative surgeries. So generally when a lump is detected, a fine needle aspiration cytology is done, and then the oncologist or the oncosurgeon decides on what type of surgery with or without chemo radiation that the patient should undergo. She may also require hormonal treatment. Now, these are the screening recommendations from world bodies. So you have to start breast self-examination at the age of 20 every month. And for clinician breast examination from the age of 20 to 39 every 3 years, and then from 40 and older annually. Mammography annually starting at age 40 is the recommendation. But having said that, there are a lot of practical difficulties and controversies regarding this recommendation. Breast cancer prevention, again, medical methods and surgical. In women, excuse me, for removal of both ovaries is recommended in women who are at a high risk because of their familial gene. So I'm sure all of you know the case of Angelina Jolie, and because she had a BRCA gene, which made her predisposed to breast and ovarian cancers, she had to undergo bilateral oophorectomy and mastectomy. But after that, she is prescribed hormone replacement therapy. So there are support groups for women belonging to familial cancer groups. We're all aware of what is unhealthy and what is good for us. It's only a question of hard choices and discipline. I would appreciate it if the listeners and viewers of this program would at least adopt a few of the recommendations that I've put forward in this presentation, starting with a healthy living. And I am aware that everyone likes to eat tasty food, but tasty food is not always healthy, and it needs a lot of self-motivation to get up and exercise daily. But if you start doing it in groups, you can do it even online. You can form groups and fix timings. I'm sure you can start making a difference. I'm ready to take questions if there are any. Thank you.
Now it's time for the discussion. Before that, dear participants, the feedback form of the webinar will be provided in the chat box. Kindly submit the feedback, and these certificates will be provided only after submitting the feedback form. So now we go for discussion. Okay.
Good evening, ma'am.
Good evening.
Thank you for the wonderful talk. Shall I post the question in the comment box or just ask directly?
I think it will be better if you read it out.
I just need to know how long will it take for the periods to occur after PPH? Is the question audible?
Yes, it is. Generally, a woman who has delivered and is lactating round the clock, right, may not have regular periods for as long as she's lactating.
Okay.
But if she's also got postpartum hemorrhage, which was so severe that it caused a reduced blood flow to her pituitary. Yes, what we
Okay.
call a Sheehan syndrome. It is quite rare, but it is a possibility, and I have seen a couple of cases in my career where she never resumes menses unless and until endocrinological intervention is done. But all other cases, even if she had postpartum hemorrhage, it shouldn't really affect her menses. It depends more on whether she's lactating regularly or not.
Okay, madam. I have one more doubt.
Yes, please go on.
Yeah, madam. One more doubt. That is, if scanty periods is happening, will that be normal if it's at regular intervals? Is the question clear?
Yes, it is. It is. By scanty, does it fit the definition that I projected? Is it less than two?
Yeah, ma'am.
Less than 2
It
days?
is also less than 2, and the volume amount is also very less.
Right. So it qualifies to be called hypomenorrhea, which is lesser flow. It needs to be evaluated. It could be due to a variety of causes. It might be because she has put on weight, especially if she has just she was lactating. People tend to eat quite a lot and gain a lot of weight without exercise. Or it could be polycystic ovarian disease, it could be hypothyroidism. So she needs to evaluate. She needs to be evaluated. I hope that's clear.
Okay, madam. Thank you for. Yeah, madam, it's very clear. Okay, thank you very much for the informative and valuable talk. Thank you very much.
My pleasure. Is that all?
Questions?
Now I invite Dr. Vinishma Raju, Assistant Professor, Department of Zoology, for the vote of thanks.
So good evening all. Respected and the most distinguished chief guest, our principal, speakers of the day, my HOD, organizing committee members, friends, dear students and their parents. On behalf of the Health Education Club and the Department of Zoology, I take this opportunity to propose a vote of thanks to those who directly and indirectly involved in this webinar. At the onset, I thank our chief guest and resource person, Dr. Megha Jayaprakash, who shared time from her busy schedule to grace the occasion and the valuable information she shared with us this present time and making this webinar a meaningful and interesting one. Thank you, ma'am.
Thank you.
Next, I would like to thank our beloved principal, Dr. K.C. Preeta, for her constant enthusiastic support. Thank you, ma'am. A special thank to organizing committee, especially the coordinators, Srimati Preeti, and other members of the club for the motivation and dedication to make the webinar a grand success. Thank you. Further, a big thanks to our HOD, Dr. Leji, for her great support for this webinar. Thank you, ma'am. I need to mention my deepest sense of gratitude to our Trust Executive Member, Sri Aji SRM Sir, for his constant support. Thank you, sir. I am immensely thankful to our former principal and HOD, Department of Chemistry, Dr. Jolie, who has been with us during the session. Thank you, ma'am. Also, I am happy to express a vote of thanks to the HOD, Department of Commerce, Dr. Soju, for his support in conducting this seminar. Thank you, sir. I especially thank the people, our technical member group, that is Manu sir and Master Surya Kiran, for their support in conducting this seminar. Thank you. Next, I express my gratitude to all my colleagues and friends from our college and also from various other institutions by enriching the session by their presence. Thank you all. And finally, the wonderful students who have turned up in such a great number from our college and also from other various institutions. Thank you all for your kind cooperation. And once again, I want to say that we are almost grateful to all the participants in this webinar. And thank you all for being with us throughout the session. And it's been really a great pleasure. Thank you all.
I extend a deep gratitude to our resource person, Dr. Megha Jayaprakash, for being with us and for giving us a very useful and informative session on common Gynaec problems. Thank you very much, ma'am. Thank you, participants, for your presence. Thank you all. The participants will be provided e-certificate. The webinar has come to an end. Thank you.